Welcome to Dentists in the Know. This is your backstage look at current trends, politics, and education in the dental world. We are live from Dink's headquarters in Buffalo, New York. New Dink's headquarters in Buffalo, New York, where two of the faces you see on this screen are now broadcasting from. This to my right is Dr. Chad Duplantis. Down below me is Dr. Marc Geissberger, who is going to be our interviewed guest and a fellow Catapult teammate that I've lectured with many times, and just a super guy. And of course, down there, catty corner for me, is Dr. Jennifer Bell. We all know her as JB. We are all practicing dentists. We are all educators. We're all business owners. Our job is to bring all of you in the know. For everyone out there, Marc is one of the educators in Catapult that I've really just always admired, just because of he's so proactive when it comes to preventative dentistry and just looking at new ways to not just diagnose disease, but to prevent disease and how to keep patients healthier. So I'm really excited to have Marc with us, and he was gracious enough to agree to be on this. One of Marc's areas of focus really is in preventive dentistry and in understanding disease and preventing disease. So Marc, we don't want you just to be a guest. We want you to chime in during the news, wherever you want, and
absolutely
throw your 2 cents in, because it's always appreciated. So, Marc, you're doing a really cool program tomorrow, and I've heard pieces of it, and I've heard you do shorter lectures of it, but you like to talk about the oral cavity under attack. And why don't you tell everyone out there, because I absolutely love this topic, and I've watched the audience and how engaged they are when you do this, because it's not just a presentation that dentists can take something away from. It's even when Ginny, my wife, was in the room, she's like, that was an amazing lecture for anybody to be sitting and listening to, not even knowing that it was a dental lecture per se. So why don't you tell everyone out there about what you like to talk about and what the passion is behind that.
Yeah. So there's, up until recently, as dentists, we saw the main 3 diseases we treat as caries, periodontal disease, and occlusal disease, and those were kind of the 3 biggies in any general practice. And the reality is there's so many diseases driven by acid. You look at erosion, you look at some bruxism, and the components there with GERD. All these disease processes are governed by acids. And it's really interesting, the human body's pH, our systemic pH, is 7.36 to 7.44 systemically. If your pH fluctuates out of that zone, you're in the hospital. You're sick, you've got a blood panel, and trouble ensues. In the oral cavity, we'd have these huge pH swings, enormous, based on either what we put through our mouth or what comes up from our stomach. Those are the 2 sources of acids. But the interesting thing, and this is not talked about too much, is, periodontal pockets or carious lesions. Those have a lot in common. The pathogens that create those diseases all release acids as byproducts of metabolism. And those acids act on tooth structure in a very unique way. They also act on hydroxyapatite of bone. So it's always puzzled me why you could have a patient in your practice who's got an absolutely filthy mouth, crud everywhere, and they never get a cavity. And then there's other patients who actually keep their mouth quite spotless, yet every time you see them, they've got a new lesion. Same thing with perio. You've got some pretty disgusting mouths that never get perio, and other mouths that are quite clean and always have this chronic underlying perio. And I think one of the missing links is balanced oral pH, because we know that for disease to take place, those microorganisms need an acidic environment. So I really stress, bringing the oral cavity into balance, like our our circulatory system does, and working towards that and eliminating these sources of acids if you can, or getting strategies to deal with that. So it's something I'm really passionate about. I enjoy it. And I think it offers something new to a lot of practitioners who haven't thought about that. But you think about it, I mean, any one of us could declare the month of December class 5 month. And you could say to your team that all we're going to do is address class 5 lesions for the next month. And
I've actually limited my practice to that now.
You could
Yeah.
literally fill your schedule with class 5s all day long. Because so many of these lesions go untreated. We see these huge abfractions. I had a patient the other day with a toothache. He had abfraction into the pulp.
Yeah, I had one a couple weeks ago.
Did you? It's crazy. I'm like, okay, now let's see. We're going to do a root canal. We're going to shove a post in there or something. Then the only thing left is the lingual, but we'll cut that down for a crown, and then the whole thing's going to snap apart. I mean, these diseases are so out of control, and we haven't really got good protocols on treating those non-carious, class 5s. So
it's interesting that you bring that up too, because a lot of those things tend to start as an acid attack, and of course we know the cementum there's a much higher critical pH than that of enamel. But now, once you have that lesion there, now there's all these other factors we need to start thinking of, right? Particle size, toothbrush abrasion, and food abrasion and other things. So what kind of protocols do you have in your initial exam when you're talking with a patient to kind of break those things down?
Well, the first thing I do with every new patient, and have for 8 years now, is we do a salivary assessment. And they go through a 5-minute exam on salivary production, resting pH, stimulated pH, and then we measure their buffering. And this is really interesting, Jeff. Every new patient I've had in the past 8 years has always said the same thing. That's really interesting. I didn't know that when we talk about pH. They all say that. And then they also say, I've never had this done before. Mm-hmm. I have yet to have a new patient who said, oh yeah, I had this done before. Now, when you say 323, 333, and you do your perio exam, they say, I've had that done before.
Right.
But, we do our caries screening, and I just have it as part of my protocol to do that. And then we talk about strategies to, kind of alleviate some of those acids. But here's the interesting thing. I've noted this now after 8 years. People who have a healthy mouth, a clean mouth, free of disease, and are generally healthy themselves will always have a balanced pH. Individuals who come in with disease, whether it be systemic or oral disease, oftentimes have an out of whack oral pH. And I don't think we're given enough credence in the dental community. I always tell patients, I joke around, I say, listen, when you go to the doctor, you pee in a cup. When you come to the dentist, you're going to spit in a cup for 5 minutes.
Please don't pee in it.
Please don't pee in it, because it'll really throw the test off.
You're going to throw off the test.
It'll throw off the test miserably.
I think, Mark, what you have that a lot of people really need to think a little bit more about, including myself, is that you have a knack for educating people as to what the benefits are of this procedure. I think dentists get so wrapped up in becoming the mechanic rather than the oral physician. We fix the problem, yet we don't fix the root cause. We fix the result of the problem. Maybe we don't fix the problem. And so when you start getting down to the root of it, and that's what I've always loved about you. And that's one thing that Jeff said, Jenny said it. I think all of our wives kind of have a crush on Mark because they all got it. When you spoke to a group of dentists, pardon my term, Ellen, but the lay people got it, you know?
Yeah, they're actually oftentimes more into it than the dentists. They're like, oh God. It's more I have to do. The dentists look at it as it's more I have to do. The lay people, especially like sales reps, sometimes will go, oh my God, I was like so fascinated by that. That was really interesting. So it is interesting.
Do you have that slide handy of the Gatorade and Sprite and Coke and all that stuff?
So I have a couple of slides that
feel free to share your screen, because I think those are there's like 3 or 4 slides in there that just tell the whole story that of what you're talking about. Jeff, you okay with that?
No.
Okay.
No,
Of course I
That
am.
got awkward.
yeah, let me
Look at the guy
Look
smarter than
it
me.
up,
Look how many more
because-
books he has.
look it up,
There's a
because
lot.
while you're doing that, I'm going to tell everybody a little story. So like I said, Mark and I have known each other for a number of years. Mark and Jeff have known each other probably for a little bit longer. I don't know, maybe the same amount of time. I knew Mark before my days in Catapult and since then, but Mark practices just outside of San Francisco, has a lovely home, wonderful family. Everybody loves Mark's wife. We don't really care that much about Mark, but we love
yeah,
Christine.
I know it's tough.
Mark taught my
Welcome to
wife
that
how to
club.
Mark taught my wife how to gamble, which was
Oh.
rather dangerous, but she won a lot of money that night.
She-
But one of Mark's coolest stories that I think everybody would find interest in is Mark was the dentist of a particular star. Am I okay to share this story, Mark?
yeah.
So Mark was Robin Williams' dentist, and Robin Williams actually had a appointment the day that he took his own life, and I saw a side of Mark that was, I learned a lot about how great of a person Robin Williams was, and how much it meant to Mark to have him in his practice, and how compassionate Mark was as the caregiver to Robin Williams, and cool.
He was a super special man. Very kind. You think, hey, he's going to be hilarious when he comes in the office, and laugh and joke. And he did, but he wasn't that always like fiery guy. He was far more quiet and serious. I'll tell you, he made all his own appointments. He
Did he
never
really?
missed an appointment. He would be there 10 minutes early, sitting in the waiting room. And unlike other celebrities we've treated, he was just a regular person. And I just can't say enough about him. We shared, like you, Chad, the love of cycling. He was a big cycler.
He loved his Pegorettis, man, his Dario Pegorettis.
He had a huge selection of bikes, but he was just a really, really nice guy.
He's like one of those people that I would have absolutely loved to have been in a room with, just to have like a really nerdy conversation, because it's so obvious the guy was just a genius.
Oh, he was so smart.
Yeah.
So smart. Yeah.
So
Chad couldn't really have that conversation with him, but we could.
No, I couldn't, but he was.
Fortune Cookie has already predicted this.
So Robin Williams' passion, and I know this just through reading and my love of cycling, but Robin Williams' passion, people love artwork. Robin Williams loved artwork in the form of cycling. And so there's a bicycle maker out of Italy called Dario Pegoretti is his name. And Dario fabricates these bikes, and they're fantastic, beautiful pieces of art. And they sell for about $16,000 per bicycle. And I think Robin would call him and order like 4 a year. I mean, he had the largest collection of Pegorettis, and it was just really cool because he truly loved it. And Mark and I shared that story many times, but anyhow,
biking in San Francisco is no joke.
No, it's no joke.
Yeah.
Hey, I got a couple of slides. You want me to show you the sports?
Yeah,
thing?
throw
I'd
those
love
up.
to. Can you share your screen, Mark?
Yeah, give me a sec.
Sure.
It says host disabled my screen.
Chad, you gotta
Yeah.
allow him. Allow screen sharing.
Okay, there you go. You're good. Try that.
Yeah, let me try.
So when we moved to our new Dings headquarters here in Buffalo, New York, we didn't bring the production team with us. So,
There we go.
all right.
Yeah, so this is really interesting. I always pose this question to the audience: which of these drinks is most erosive? All right, so I do a show of hands, and inevitably they all get votes. Usually, Coca-Cola gets the most votes, and it's actually quite interesting because the way I phrase the question is not which one has the lowest pH; it's which one is most erosive to tooth structure. So years ago, I was working with a guy named Terry Donovan, who you probably know in the dental literature, and Ward Noble. And we published this article where we measured the buffering time of these drinks. So it turns out this: you take a swig of Red Bull. Red Bull is actually the most erosive. You take one swig of Red Bull and it takes your mouth 22 minutes to recover to a normal pH, to buffer that acid. Gatorade's not much better at 21 minutes. Powerade is, right behind it because it's made of the same stuff. But oddly enough, Coca-Cola is not all that bad. It buffers very quickly. Even though Coca-Cola has the lowest pH of all those, it has nothing to do with the pH, it has to do with the type of acid. So Red Bull, Gatorade, and Powerade are all citric acid-based drinks, which are hugely devastating. Coca-Cola is phosphoric acid. And we know as dentists how easy it is to rinse off phosphoric acid and neutralize it. So then you look at other things in common drinks and what acids are in them. Suffice it to say, the stronger the tea, actually the higher the pH. So your lighter teas, and your lighter coffees actually have a higher pH or a more acidic pH than your darker coffees. Carbonic acid, I always get a question about, hey, what about soda water, plain old soda water? Isn't it just water? I'm like, no, it's actually got carbonic acid in it, which has got a pH of 3 to 4, pretty darn devastating. Takes a little while, about 5 minutes to buffer that. So, and then when you get into the alcoholic drinks, you guys will be love to know that
Most interested.
Now I'm going to show you something you're going to love. Most of your alcoholic drinks are pretty darn acidic in the 4 to 5 range, which we know is all too structured, especially if you're a Sunday sipper. So I always tell people, you're going to drink, guzzle, get it done. Don't let your teeth bathe in this stuff.
That's my excuse, everybody.
That's right, man. That's right. But interesting, this is funny though. If you look at what I think are the new popular drinks, these hard seltzers, they're actually the worst for us.
Yeah.
They're just like Gatorade. They're no different.
When you say the pHs, but what's the buffering of these things versus?
Okay, so all you need to do really is to look at the type of acid. So anything on here that says citric acid is going to be the hardest to buffer.
Right.
The other acids on here actually are a little easier to buffer. So wines have citric acid, grapes contain citric acid, so they're pretty tough. But anything with citric acid here is harder to balance. Now there's one bit of good news out of Texas, Chad. Have you heard of this vodka?
No, I have not.
Okay. People, pH of 8.
What?
Yes.
No way.
Yes, it's a buffered vodka. It's distilled 10 times. It's made in Texas. It's made by a company owned by 2 women. They wanted to be the first alcohol that's pH neutral or basic. So, for the people who need a non-acidic drink, this is probably good. You can't, of course.
So they put their seltzer and
yeah, they put their soda water in it.
I'll have a fix and lemonade.
Yeah.
So again, drink it straight. I'll show you one more slide and then I'll let you go. So this was a very interesting article in JADA back in 2016 that looked at 379 drinks that are sold in grocery stores across the US. And what they found was 93% of them had pHs that were really, really low. Yeah. So I stress, talking to patients about what it is they drink. And are they a sipper or, do they drink quickly? I used to watch kids play sports and they sit on the bench for 2 hours during a game and sip Gatorade. They don't need it. They didn't get any play time. And they're literally destroying their teeth.
I have had this conversation with patients with bottled water because a lot of them don't realize that if they're drinking bottled water, it's also acidic because it's shelf stable. And they seem to have an awareness, but I think the whole point or value in that, see, there you go.
Yeah, so really
the whole value in that conversation is to, I don't know, patients come in and their guards up and they're ready to defend their diet and hygiene and, all the things. And to your point, when you start doing saliva testing and you have real conversations about the stuff that they're exposed to and coming in contact with, and you help them understand the dynamics of karyology and periodontal disease and how, different things play a part. Don't you kind of feel their body sort of just let down a little bit? Like,
Yeah,
No?
although it's so weird because I'm in Marin County, which is like one of the healthiest counties in the country. So they're actually, a lot of my patients are really into this stuff. When I tell them, hey, you know what, Dasani water or Aquafina is actually acidic enough to dissolve root structure, they're like, what? And I'm like, yeah, pH of Dasani is 5.6. That's enough to start dissolving root structure. Maybe not so much on enamel, but it's in the zone of tooth loss. So, they're interested in it. But yeah, some aren't. Some don't want to hear it. And you can tell pretty quickly by body language. They're like, yeah, I don't want to hear it. You're right.
So all I can think about is one thing, Mark. Go back to the alcohol slide.
I knew you'd want to go there. All right, let me find
No, because obviously my eyes always kind of drift down to the bourbon and the whiskey. And tell me about. I am not familiar with that acid, ellagic acid.
Yeah, I think that's an acid that's found in either barley or the wheat, but I'm not sure.
What do we know about the buffering capacity? Because obviously that is a sipping drink.
Well, so here's the cool thing.
And for some of our other dinks out there,
you could do this study on your own. It's really quite simple. What you do is you take.
I think I do pretty much every day.
Yeah, you're going to do this tonight, Jeff. You're going to get a pH strip, okay? You take a swig of the drink. Well, you measure your resting pH. It should be 7. You take a swig of the drink. You immediately measure the pH. And then you measure every minute your pH until it returns to normal. So you just stick that strip in your mouth and look at it until you're back to normal. And that's how you tell the buffering time. Okay. So, and that's with average salivary output. Someone with lower salivary output is going to have going to struggle more with that than others. So when we did this test, we did it with when we tested the pH, we did it with average salivary output of 15 mLs per 5 minutes of chewing. So we found individuals who tested normal.
Yeah. But and that's something that even I think a lot of the dentists that are out there listening now are going to be like, well, how do I measure all this stuff? And there's really some simple kits that are available from companies like GC that will allow you to measure salivary output, buffering capacity. You want to talk to that a minute?
Yeah, so GC makes their salivary check buffer, which is a kit with enough material to test 20 patients. I think the kit's like $100 and something bucks. And oddly enough, our codes now have 2 salivary diagnostic codes we can bill for as a separate procedure. We incorporated into new patient exam, but you can actually charge a patient for in-office salivary diagnostics. Somewhere in this presentation, I actually have the codes you use to do that. And one is specifically designed to test the pH. So those are new codes in our dental codes. I think there's 6-8 codes. So if anybody wants to look.
So just to clarify, you're tying that into your new patient exam. You're not, if someone comes in uninsured, you're not, putting that as
it's a value add.
Yeah. So when
I agree with that.
When I decided to start doing this, I said, okay, I'm going to obviously do a caries screening. I'm going to do a periodontal screening, and I'm going to do an acid screening. And all that's just part of the exam process. And this is what I charge for the exam. My thing is, at least I found with my patients, as soon as you start itemizing things, there's some negotiation that goes on. They want to start negotiating things out.
Can we do no x-rays, but add the fluoride?
Exactly. I don't want the fluoride this time because you charge separately for it. I've often thought that we just simply said, this is what a cleaning is. It includes a fluoride. You're paying for it. Even if you don't want it, that's the cost. But we don't work that way. We're always itemizing things. So it doesn't always serve us well. I'm going to get out of my slide so you don't have to look at that. It's making you thirsty. I know. I'm going to stop.
On the acid screening, do you check for a history of flashbacks or any sort of adverse tripping reactions?
That is hilarious.
No, I do have a serious question though. Did you do any of the buffering capacity, like when you talk about the Red Bulls or the Gatorades of the sugar-free versions versus the traditional versions?
I did not. We did not. I would guess that there's little difference. because
I'm
the
just
amount of-
curious because you know that the byproduct of sugar breakdown is
Right,
acidic.
right.
So I was just curious if that would increase the buffering
I would think
capacity.
in a
or
dirty mouth with a lot of bacteria, it would. If the
Yeah.
bacteria in the mouth start metabolizing that, the acid level might, be prominent enough to take a while to buffer.
Okay, so let's say that a patient comes in with a very limited, with high acidic content, salivary acidic content. What would be your course of action?
So first and foremost, I have almost every patient that test acid positive or they've got a pretty caustic pH. I get them on Arm & Hammer baking soda toothpaste.
Okay.
Baking soda is literally the most effective way to neutralize acid.
Okay.
And, we used to think that baking soda was highly abrasive. It's not. It's 7 on the RDA value. So that's my strategy first and foremost. I like to do things that aren't going to, as soon as you pile new stuff on a patient, the compliance is tough. So I'll start with things that they're likely going to do. Let's just switch your toothpaste. Here it is. We start there. For dry mouths in combination, I'll actually have them do a sodium bicarbonate rinse whenever they can throughout the day. So have a quart of water with a tablespoon of sodium bicarbonate, gargle, spit, gargle, spit. The other thing that's actually really effective, and the literature shows us really clearly, is gum chewing, oddly enough. So when you chew gum, you actually trick your brain into thinking you're having a meal, and your brain sends a message to your parotid glands that tells your parotid glands to add buffers to your saliva. So
is that because of the xylitol?
No, it's just because of the action of chewing. So this is an interesting thing. There's, acidic mouths. One of the proposed theories on some forms of bruxism is that it may be protective against those acids. You brux, and that bruxing is like chewing, and that raises the pH of the saliva. So gum chewing is super effective. You can take a piece of gum, test your pH, take a piece of gum, and your pH will rise from 7.0 to about 7.8 to 8.4. And keep in mind, there's no acids to counteract, so you're just keeping your pH nice and high.
So basically, you're secreting unaltered saliva, which increases the pH by diluting the already acidic saliva?
No, your system adds buffers to the saliva as soon as you start chewing. It's really interesting. You have stored calcium and phosphate in your salivary glands that is released as soon as you start chewing. It's crazy. That's why you see a big spike in the pH.
And I think that's probably one of the biggest takeaways is and I would encourage anybody to take one of your classes because you learn so much about, there's so many topics that you teach upon, which we'll get to in a minute, but basically with this is not just, how to test for it, but how to treat it once you've tested for it too. Yeah. And have you heard of anybody what about, maybe a dumb question, but instead of Arm & Hammer baking soda, what about just mixing baking soda and water and rinsing with that?
That's great. Okay. I'm old enough. And Jeff can attest to this too. We had patients in our practice when I first started practicing who would report that during the war, all they could afford to brush with was baking soda and water. And it's interesting. A lot of those people have absolutely amazing mouths, no fillings. And I've seen it time and time again, not just, an N of 1 or 2. It's a lot of these patients who grew up at that period have really good teeth. And that's probably likely due to the fact that they kept that pH in a zone where bacteria couldn't thrive, and enamel didn't dissolve away.
Yeah, and it was a non-abrasive material at the same time.
I remember a lecture in dental school by a periodontist who said, never let your patients brush with baking soda. It's highly abrasive. And I actually practiced for 15 years believing that. That's what I was told in dental school. I don't know. Did you guys ever get told that by someone in dental school?
Oh, yeah.
Yeah.
Absolutely.
Yeah. It's hilarious.
100%. Unbelievable.
Yeah.
So this stuff is so enlightening, and we're a little bit off on our time tonight. I think we're at about 35 minutes, or excuse me, at about 55 minutes or so that we've been doing the broadcast, and so we don't want to keep everyone all night. But if you've not had a chance to ever hear Marc Geissberger speak, I'd highly encourage you to get to one of his lectures. He just does a terrific job. It's very laid back. It's and it's something that if you can bring your team to, they'll sure get a whole lot out of it. So I know the people here at the Buffalo Niagara meeting are gonna have a great lecture with you tomorrow. Marc, thanks so much for being with us. Yeah, have a great lecture tomorrow, and I'll see you tomorrow night.
I will. Absolutely. Thanks you guys for having me. Jennifer, Chad, Jeff.
It was
Good to see you, brother. Miss you,
All right.
man.
Just a few small topics. We don't have to get too deep in the weeds, but you should know that the current version of the trillion dollar bill, the infrastructure bill, Medicare dental benefits gone.
Yeah, I saw that.
That's important to note.
I got that email from the AGD, and I was excited to see that.
Yes. So that was a win, I guess. We'll see. Who knows where that will all go? None of it's really been ironed out yet. What are you doing?
He's
Are you-
admiring my bookcase.
Yes. And then the other thing that I think is worth mentioning that, we had posted about the ADA's comment last week where they made a statement about unvaccinated dentists. I got to be honest, I wasn't comfortable with where they went with that ethical line. I'm super uncomfortable with the current line that they've made where we're not to treat, he's really pouting. Okay.
He's really pouting.
Where we're not to treat unvaccinated patients. And, we don't have to go too far back in history when the HIV crisis was going on. And I will readily admit I was not practicing during that time. I was alive during that time, but I was not a practicing dentist at that time. But as best I understand, there was no option to, remove yourself from treating patients who were HIV positive. In fact, that was considered discrimination.
Right.
And we had to develop infection control protocols to ensure that we were keeping both patients and staff safe. And I think those have really stood the test of time. And I have to say, probably a good number of those things have protected us from COVID as well, because the statistics say
it's why there were so few transmissions through the dental office.
This may upset people, and that's okay. My belief, this is not news, it is an opinion, this is an editorial, is that I'm not prepared to discriminate anybody who comes into my office for any reason, other than just lack of apathy. If they don't show up and they don't want to pay for services, that's a whole different conversation. But because of pre-existing conditions or personal choice, I've chosen to treat anybody who decides to make a new patient visit in my office or a recurring visit. So, I don't know how other colleagues are going to feel, and maybe some will respond. And if they're super passionate about drawing the line in the sand on vaccinated versus unvaccinated, I just think it's an interesting change in 25, 30 years of not discriminating against those who have infection control issues. And then now we can. I think it's worth discussing.
It's worth discussing. And I think that there was really not a need for that to happen at the time that it happened. I mean, sometimes it's best to let the science settle and continue with the infection control mandates and the infection control protocols that we've had to see how it all shakes out. But to come out with such strong statements, I really feel it's going to hurt them long term. There's no way it won't. And right now, organized dentistry can't afford to lose any more support. We see what's happened on the medical side, where I forget what the percentage is of physicians that are actually in the AMA. It's really low.
15% or 15%.
Yeah, and we're watching the numbers come down in organized dentistry. Not to those levels at this point, but things like this where they don't have the backs of the average practitioner, I think just ends up shooting them in the foot. So
I just don't want to see a healthcare system in general. This is my own personal belief. I don't want to see a healthcare system in general that starts to deny care to anybody for any reason. I don't deny care to smokers, or, we can go to Marc's lecture and dive in. I don't deny care to anybody that consumes any of those beverages or lifestyle choices, or is a genetic predisposition towards caries or periodontal disease or smokeless tobacco every day.
If you have an IV needle user or a past IV abuser, and there's a high likelihood for hepatitis C, and do you say, okay, there's a high risk that you have hep C, so I'm not going to treat you? Yeah, I mean, do we tell people not until you stop drinking? Not, I'm not going to treat you until, we're just not at liberty to do that. So
I know. So that was uncomfortable for me, as a clinician. It was a little bit uncomfortable. So those are the two big things that I've seen. Obviously in national news, COVID vaccine approval for 5 and up. And so, that's moved through. Boosters are available for everybody as well. So that's continuing to push forward. Yes, Chad.
Sorry, I didn't want to interrupt.
I love you.
We missed you.
It's funny. I just got to say this. I was totally joking and pouting. And so I turned my screen on.
Jennifer.
It was only on this end. And so y'all could still see me. And I was laughing because all I could see was you two. And I looked at it and I'm like, oh, that didn't work the way I thought it did. I really
No, we couldn't see you at all.
Yeah.
Okay. So anyways, the COVID from vaccination 5 to 11, that was approved by the FDA, right?
And the CDC.
Did that just go through today?
Late last night, the CDC approved it.
Okay, because I heard it was about to, and then of course today I was caught up in other stuff, and I did not see where that was. I didn't imagine it'd go as quickly, but it's weird because the FDA and the CDC just haven't quite been on the same page for a lot of this. But that's kind of shocking to me. And
there was something. I'll try to pull it in. I saw something today, and I'll have to pull the source, that said that there may be some discerning factors in who 5 and up will be to receive the COVID vaccine. And that it might not be a release, but yet Walgreens and like other major pharmaceutical chain or pharmacy chains are now offering it. And so I don't know what that discernment will be.
I'd like to be the dentist who tells the parent of an unvaccinated child that you can't help their child with caries. I'm not going to be that guy.
I won't be.
Nah.
Yeah. I'm okay. Well, it's so different. I mean, I've been doing this we're now almost in 2 years. Like to me, it's so much of this regulation is so late to the game
that's the other point.
For us anyway,
I just find it so weird how this virus A transmits so differently and B affects everybody so differently.
Also, you're a professional that understands infection control and takes the time to implement processes and procedures that mitigate infection transfer. That's what we've done the whole time to come at it at this point of the game.
Would that be referred to as universal precautions?
Yes, thank you.
Oh, okay. Yeah. I'm just curious if that was kind of forgotten in the past. So,
right.
Yeah. So,
Good point, and I think we should end on that because we're running late. We did the news at the end, but I think that's something really good to think about, and I hope people will chime in on dinks. You know, we don't always have to agree, but you know, the old John Coy saying, it's okay to disagree. It's just not okay to be disagreeable. We can absolutely have great discussion about it, and let's talk about it.
I think to that point, clinicians just have to be okay to say, I am uncomfortable treating the unvaccinated, or I'm comfortable treating the vaccinated, but make sure that everybody has a home. Because I'm okay if someone else has pre-existing conditions and other reasons why they feel at high risk for contracting COVID, and that might be something that would be very serious for them. What I don't want to create is a professional lockout where those of us, and I would put myself in that, on the younger end of that spectrum with minimal comorbidities, I'm okay to accept that risk so that others don't have to. And I think that we all just need to be able to be comfortable saying, I'm okay with that risk, or I'm not okay with that risk. And there's a no judgment zone on that. It just, you know, and maybe to the ADA's point, it's saying, you know what, if you're I guess in a better phrasing of it, if they had just said, based on your own susceptibility or your staff's susceptibility, if you feel uncomfortable treating the unvaccinated, then just ensure that there are patients with, or providers within your periphery that are comfortable with that, so that at least everybody can find a home to get the preventative dental care they need. Because we do know that there was a huge gap that happened when dentists went offline for a period of time. And I think we're all still playing cleanup to the COVID lockout that happened for
well, lots of physicians for that matter, the uptick in cancer diagnoses and other ailments that went untreated. So really expands.
I've seen patients for the first time that haven't returned to our office since COVID, and we're a solid 18 months in on that. So, you know, I just want to make sure that patients have a safe place to go and that they feel welcome and have access to care. That's, you know, at the end of the day, that's all that matters.
I love it. Let's keep the conversation going. Let's, guys, we need your help. Invite your friends, invite your colleagues to Dinks. Lots of really cool stuff coming up for 2022. We've been kind of meeting on the sidelines, talking about some of the great new things that we're going to be bringing to you in the new year. It's really been exciting for us. Lots of great things to come, but we need your help. Ask your friends and colleagues. Tell them to join up with us, and we'll look forward to seeing you again next week and talking with you online. And you guys have a great night.
Have a great night, everybody. Thank you very much.